hand.
Good morning, good afternoon, good evening. It's our pleasure to present to you on behalf of IPA the webinar on cross-cultural perspective on dementia, the African perspective. The organizers are Maria Lapid, she's a professor at Mayo Clinics in the States, Dr. Rob Medan, he is the Deputy Chief of Staff in Baycrest, Canada, and I am based in the Netherlands. The IPA, so I will, can I have the next slide, please? Yeah. The IPA is dedicated to mental health of older people. It's world's leading multidisciplinary global psychopsychiatric organization. And that's why our focus is this time on the African perspective. Next slide, please. We have a format, and there are several technical issues. You can use a chat box to ask questions anytime during each presentation. So if you want to pose questions, and when it comes up, please put it in the chat box. All attendees will be muted. And if there are technical difficulties, you can try to log off and back. The webinar is recorded. The webinar series, they originated during the COVID period, and now this one is number 11. And our format is that that we really try to engage you as much as possible and to give you the floor. So there are two presentations, and after the presentation, there will be the opportunity to ask questions about both lectures. The next is the next slide. Okay, before we start the presentation, I would like to introduce Professor Solo Ogunniyi. He is from Nigeria, and he is part of the African Dementia Consortium. His special interest is in epidemiology of dementia, in care arrangement, and in stigma. It's pre-recorded, and we are going to give the floor now to Professor Ogunniyi.
Hello, good afternoon, or good morning, wherever you may be, and I'm very grateful for this opportunity to present at this webinar. My name is Adesola Ogunniyi. I'm a professor of medicine, College of Medicine, University of Ibadan, Nigeria, and it's a big honor to be asked to talk on the African perspective in this session on cross-cultural perspectives of dementia. My topic is epidemiology of dementia in Africa, care arrangements, and stigma. This is the outline of my talk. After a brief introduction, I'll go on to talk about the epidemiology, both descriptive and analytic, and then go on to talk about stigma, the care arrangements, and then I will conclude. By way of introduction, we know that the world's population is aging and that dementia is a global problem. Currently, it is estimated that there is one new case of dementia in every 4 seconds, which is quite a staggering number. And the number of cases is projected to reach epidemic proportions, particularly in low and middle income countries. And the total cost of care is also enormous. Currently, it's believed to surpass $1 trillion globally. And for Africa, it's about $6.2 billion, which is beyond the resources available in most of these countries. There's this paper on the global prevalence of dementia, looking at figures between 2019 and the forecast for 2050. And there, I can just summarize that the number of people with dementia will increase from about 58 million globally in 2019 to about 152.8 million by 2050. And the projected increase in cases will likely be attributed to population growth in sub-Saharan Africa, unlike in Asia, where it will be due to population aging. And this is the graphic representation of that, showing the percentage increase in number of cases between 2019 and 2050. You can see that Africa is painted in red. And if we look at the key to it, means that we expect increase between 300 and about 2,000% in Africa compared with the rest of the world. So this is quite worrisome. And it shows that in this slide that the majority of the increase will occur in Central, Eastern, and Western Africa, as well as North Africa, but much less so in Southern Sub-Saharan Africa, compared with Europe, where you expect 74% increase in cases. In Africa, you're expecting something over 300%. So that is a major challenge. Now, in terms of prevalence of dementia and the burden of dementia, there have been studies from about 20 countries in Africa, and this color representation from the review by Ogunniyi shows that some studies are focused on prevalence, others on incidence. Some looked at genetics of dementia, others have looked at case reports, and also some people have looked at family studies and care patterns. We know about 20 countries have provided data, so a lot of Africa is still void in terms of data on dementia. Well, the summary is this, and this is from about 26 studies that have provided data on hospital cases, nursing homes, and communities, that the prevalence rate ranges between 2.3% and 28%, quite a wide margin. And the more recent studies have tended to report much higher rates in Uganda and Zambia especially. Well, according to the meta-analysis carried out by Bahyewu in 2021, the average prevalence is about 55%, and there is evidence that the rates are rising in many African regions. Well, we know that prevalence is influenced by disease duration and incidence. So what we focused on in this slide is to present data on incidence of dementia in Africa. We can see that it ranges between 1.4% in the Indianapolis-Ibadan study and 2.7% from a recent analysis by Bala in Egypt. And the mean incidence for Africa is put at 2%, again by paper by Bahyewu, which appears to be lower than what has been reported in Western countries, or even African American, which is about 3%. So prevalence is low, and incidence is also slightly low, although the prevalence is increasing, and overall the burden of dementia is increasing. Now, we can also notice that the age for this study, the age range, or the mean ages is quite impressive, between 60 and about 80 years. So at least aging population is there in Africa. In terms of dementia subtypes in Africa, Alzheimer's disease predominates, accounting for about 57.2% of cases, followed by vascular dementia, about 27%, and then the other types, about 16%. Comparative figures for Western countries is about Alzheimer's disease about the same, 55%. Vascular dementia appears to be more frequent in Africa than in Western countries, 27% compared to 15%. And so stroke is a major determinant of dementing syndromes and cognitive decline in Africa. With regards to stroke in Africa, there are two studies that are of note, one by Ogunniyi in Ibadan and the other by Safo in Ghana. And they've reported cognitive problems in about half of the patients who are stroke survivors. In Nigeria, about 40% of the survivors develop cognitive impairment, and another 9% roughly develop dementia. In Ghana, 34% develop cognitive impairment, about 14% develop dementia. And the risk factors for developing cognitive dysfunction include older age, low education, and pre-stroke cognitive decline. If you have the luxury of neuroimaging, studies by Ogunniyi have shown that medial temporal lobe atrophy is another risk factor for development of dementia following stroke in Africa. Now, this is from the Lancet Commission on Dementia Prevention, Intervention, and Care, which shows 12 potential modifiable risk factors which account for about 40% of worldwide dementias. And part of data was contributed to from Africa. And so these are the same risk factors that we need to think about when we're considering risk factors for dementia. But there are a few additional risk factors for dementia in Africa, which include undernutrition, low BMI, especially BMI below 18.5, functional dependency, peripheral vascular disease. This is based on ankle breaker index measurements and from the Epidemica study in Congo. And then low fruit and vegetable consumption, which have been also linked with stroke risk from the Siren study. And then the more recent analysis by Adesola shows that being widowed, which contributes to social isolation, is another risk factor for dementia. So these are the predominant risk factors for dementia in Africa. The analysis by Olusegun put some weight to the risk factors, and it shows that advancing age is the major or the most predominant risk factor in Africa, accounting for about almost 96% of the risk. The others are low education, IPA, hypertension, rural residence, female gender, and pre-dementia cognitive functioning. I'm going to talk a little bit about hypertension, IPA, as I go on in this talk. With regards to hypertension, the longitudinal Ibadan Indianapolis study has provided some data on risk of hypertension associated with developing dementia. And in that study, which spanned data collection over a 7-year period, hypertension, both systolic, diastolic, and pulse pressure increased the risk of incident dementia by about 9% to about 52%. And this is one of the factors that we can work on if we want to prevent dementia in our people in Africa. What about protective factors? There are 3 that have been identified in recent studies. Exercise, education are 2 that are known because the opposites tend to be associated with dementia risk. So if you can exercise and increase your physical activity and increase education, then the number of individuals with dementia will reduce. The addition is ventilated kitchen, which is presumed to reduce inhalation of possible fumes and pollution. And so this is a recent addition from Epidemica study. Well, genetic risk factors are also important, and the one that has been investigated most in many African countries is ApoE. We know that ApoE is linked with cholesterol transport and is the most important risk factor for sporadic late onset Alzheimer's disease. Data has shown that the risk for developing AD is highest in Japanese who have ApoE, followed by Europeans, then people of African ancestry who live in America, African Americans, and lastly, we have Africans. And data from Africa on genetic risks have shown that ApoE is an important risk factor. This has been confirmed in Tunisia. Also, the possession of the homozygous E4 allele in the Yoruba also increases the risk of developing Alzheimer's disease. Although the associated risk is slightly lower than African Americans and much lower than in Caucasians, possession of a single allele does not seem to increase the risk. Other genes that are of interest include the angiotensin converting enzyme, pyroxenase 1 gene, which have been shown to increase the risk of Alzheimer's disease in Tunisians. A few other genes that have been looked at include homocysteine in Nigeria, Zambia, and Egypt, presenilin 1 and 2, and then TREM2 and CHIMP genes. Unfortunately, I'm not going to be able to present all the data because of time constraints. So we have genetic risk factors. Of interest is also this paper by Rajabli that shows that there's a particular locus on chromosome 19 that seems to significantly reduce the ApoE risk for Alzheimer's disease in African ancestry. So the field is open for more research in this aspect, and we think the African Dementia Consortium will be able to provide data on this over time. So let me go back to the second topic, which is to talk about stigma in dementia. We can see a patient with an individual with dementia that is being shackled, and this is the kind of thing that happens and should be deplored. It's a social discrediting attribute, behavior, or reputation associated with stereotyping. It's a major challenge facing family members of people with dementia. It's a universal phenomenon, but appears to be a huge problem in Africa, and is largely ascribed to ignorance, poor understanding of disease. which results in misconceptions. Stigma can be implied or enacted, and it could be detected in the way people with dementia are referred to. Some people refer to them as people who suffer from a mental disorder, a brain disorder. It's regarded as a disease of forgetfulness, or people with dull brain. Some people think that dementia is associated with shame and embarrassment. And this is the view of about a third of respondents in a study in Lalupo, Nigeria. And the most severe one is that the statement that people do not take those with dementia seriously, and about 28% of respondents. Another study in eastern part of Nigeria, reported by Wakwe, noted that dementia is believed to be caused by evil spirits, which can lead to all sorts of tragic consequences. So this is a summary by Wenda from Kenya, who says stigma of dementia, the significant problem of care, is closely linked to knowledge gap, associated with discrimination and neglect at primary health care levels. It often results in social isolation, fear, and in some cases violence and mistreatment, and the worst consequence is elder abuse. And like the picture I showed earlier, women shackled and all that. All sorts of mistreatments that can occur because of stigma of dementia. So the last part is to talk about care arrangements, and I commend this article by the Alzheimer's Disease International, which is called the World Alzheimer Report 2022, looking at care arrangements and life after diagnosis. And we can see that the summary is that in Africa, whatever the stage of the disease, early, intermediate, or late, home care is always preferred until the latest part of the illness or when you have acute decompensation. And the reasons that would make that possible will be the following factors that are listed. The fact that dementia is maybe considered as an incurable illness, the stage of the disease, the household composition, determining the number of people who may be available to provide care, tolerance of family members living together for deviant behavior that could occur occasionally, cultural and religious influences, then associated medical comorbidity, which may then warrant a need for acute consultation in hospital, presence of behavioral, psychological symptoms of dementia, which can result in stigmatization that I discussed about, and the fact that we have limited facilities for institutionalized care, because it's always considered a taboo to leave an elderly person in a nursing home rather than caring for the person at home. Overall, what services are offered compared with Western countries, we see that a lot of cognitive stimulation is provided in recent times. Then we have training of caregivers, occupational therapy, physiotherapy for those who may have some disability like stroke. But we don't seem to do well with respite care, financial advice, speech therapy, which are areas in which and home care support, where the Western countries seem to do better than us. In the next slide, I'm going to summarize the views about caring for patients or individuals with dementia. Again, the paper by Wenda, just looking at experience of caring for older persons living with dementia in sub-Saharan Africa. So in Kenya, the feeling is that caring for a person living with dementia is an adverse experience requiring significant mental and physical effort. In Ghana, it's regarded as a family affair, familial duty performed by female family members. In Nigeria, it was noted that caregivers lack the right training and information, as well as support systems to improve their role performance and reduce accumulated stress. It was also noted that caregivers typically had limited education, they were unpaid, and they were usually overworked. They worked for more than 13 hours every day. In Soweto, family caregivers are considered as perpetrators of abuse and or neglect. So overall, we need to do a lot to look after providers of care for individuals with dementia. So in conclusion, consider dementia is a global problem due to population aging. International collaborations are needed to improve diagnosis, document genetic diversity, and identify unique environmental risk factors. Stigma reduction is a must where they exist, and this can be achieved through improved awareness, support for caregivers, and advocacy. And prevention holds the key for reducing the looming epidemic in dementia in Africa. And I'd like to end by saying that it may be important to consider using dementia risk scores, which will help to identify individuals early who have the potential of developing dementia and intervening as quickly as possible. One of the things that's been done in Africa is to pull together experts working on dementia from different countries. And we have an African Dementia Consortium, which we hope by the time we finish our studies, will provide all the answers to all the areas or aspects of epidemiology of dementia in Africa. I thank you for listening. Thank you. Hello, good afternoon. Afternoon or good morning, wherever you may be, and I'm very grateful for this opportunity to present at this webinar. My name is Adesola Ogunniyi. I'm a professor of medicine, College of Medicine, University of Ibadan.
Well, my name is Olusegun Bahyewu from the College of Medicine, University of Ibadan, Nigeria. I'll be talking this afternoon about behavioral symptoms in dementia. Along with cognitive decline and functional impairment, behavioral symptoms are part and parcel of dementia complex. Studies globally and in Africa show that these symptoms predate dementia. They are part of they are part of dementia complex, and they are responsible for enormous amount of caregiver distress and increase in hospitalization, as well as increase in institutional placement. In Africa, the commonly used questionnaire to measure the BPSD is the neuropsychiatric inventory, MPI, and the symptom list is shown here: delusion, hallucination, agitation, depression, anxiety, elation, apathy, irritability, aberrant motor behavior, nighttime behavior, and appetite change. Neuropsychiatric inventory is administered to caregivers of persons living with dementia, and scores are obtained for frequency or prevalence, severity, distress. Apart from use in dementia, MPI has been used in Parkinson's disease, as well as in relationship between APOE4 and BPSD. In Africa, BPSD represents about in Africa, BPSD is present in 60 to 80% of subjects in community studies, and about over 90% in hospital and clinic-based studies. This is a list of studies done in Africa. There are 4 of them for community-based studies in 2003, 2013, 2015, and 2019. They also shown its cancer diagnosis, but more importantly is the fact that we have on the last column the 5 most common symptoms, usually depression, appetite change, irritability, in some cases nighttime behavior. In hospital-based studies, similar symptoms are found: nighttime, nighttime behavior, depression, and hallucinations, appetite change, and so things. In 1996, Gotha published this paper which showed that behavioral problems in dementia come up about the middle stages of dementia. But I think, like I pointed out before, we have now found that actually behavioral symptoms predate diagnosis of dementia. This is from a study in 2013, and it shows clearly that depression is about the commonest condition, has the highest prevalence. Interestingly enough, as shown in this slide, the depression is probably slightly less frequent in dementia than in MCI, 44 to 45% respectively. But depression was the most common, followed by apathy and irritability. And the same is true for the severity, except that here, apathy is probably more common than depression. Depression is still high on the list. When it comes to the issue of distress to caregiver, depression stands out clearly as very distressful, even in those who have MCI. And depression, irritability follows, so also is apathy. And these are the symptoms that could cause distress to caregivers who are always family members. The important thing about this study, which I just presented, is that diagnosis, is included the stability of diagnosis. During two waves in 2001 and 2004, people who were included was either for MCI or normal were stable with their diagnosis. That is, they were either MCI or normal during two waves. Dementia could be from either two waves, either in 2001 and 2004. So we have some stability in the diagnosis during this period. Lack and colleague in 2008 classified BPS into the following categories: hyperactivity cluster, psychosis cluster, multiple cluster, and instinctual cluster. Recently, we had the opportunity of looking at survivors from our longitudinal study in Ibadan, and we examined and re-diagnosed them in between 2021 and 2022. That was 10 years after we've ended the initial study. The mean age then was 92.5 years, 76% were females, and 30% attended school. Diagnosis was as follows: normal 62 persons, MCI 44, and dementia 39, total being 135. The interesting thing is that actually in the oldest old, depression still stands out as being the most common, and is in all category of people. Another interesting is that aberrant motor behavior was present only in those who had MCI. These conditions like elation, anxiety, and disinhibition were low. Were very few people who were in those categories. When it came to severity score, again, depression, comes up top, but followed this time by disinhibition and irritability. Sorry, followed this time by appetite change and nighttime behavior. In this stress, the depression, it was very distressful to family members. So also was delusion, But probably more distress to family members was appetite change in the oldest old. Well, this slide is from Tarot et al. And it's credited to clinicaloptions.com. And it shows the percentage of people who have psychosis, which is an important symptom among the behavioral symptoms of dementia. And 30% had had psychosis in AD, 15% in vascular dementia, 75% in Lewy body dementia, 50% in Parkinson's disease dementia, and 10% in frontotemporal dementia. Prevalence of dementia from global studies, up to 95% of persons with dementia develop BPSD. Over 80% of the BPSD persist for up to 18 months, and BPSD predicts functional decline and cognitive decline, as well as institutional placement. BPSD results in excess disability, and it leads to premature institutionalization and suffering for both patients and caregiver, and substantial increase in financial costs. Well, this is the treatment protocol for BPSD and dementia, of course, for dementia generally. Non-pharmacological treatment methods are shown here. Education to caregivers and environmental manipulation. But more importantly is that in Tanzania, our colleagues there found that cognitive training was useful to residents in the community. For pharmacology, the treatment consists of cholinesterase inhibitors, like shown, momentin, and recently anti-amyloid drugs have been approved, but of course not in Africa. Treatment of BPSD per se consists of a serotonin specific reuptake inhibitor for depression, and atypical antipsychotic for psychosis and agitation, and as well as others. But atypical antipsychotics have been said to have side effects that are toxic, and most regulatory agencies advise caution. Recently, pimavanserin, a 5-HT2A specific agonist, was approved for psychosis in Parkinson, but it is thought to be useful also in dementia. Well, a number of cultural issues occur in Africa. Dementia is regarded as part of aging. There's a stigma towards BPSD, and often thought to be due to devil possession. BPSD is the reason why most persons living with dementia are brought to hospital, and some families stop coming once they have a relief of this condition. Elder care is family care, usually carried out by younger families in the family, daughters and daughters-in-law. Filial piety demands that care of the elderly should be borne by family even when there is distress. Many people, include those in government, believe that nursing home placement is not in consonance with our culture. A good number of people living dementia die before they become bedridden and have to be fed. However, appetite change, like I've shown in this slide, is a common symptom in a study. In addition, loss of weight predates dementia in a study we reported earlier on, Ogunniyi et al. 2011. Well, recommendation, generally, older people should avoid loneliness, appropriate aids, eyeglasses, hearing aids, walker, etc. Continuing education for older persons and family, including giving them flyers, and information leaflets. Support for families to look after the disabled elderly, both financial and professional support, provision of daycare centers for the elderly. We need to make primary care healthcare centers carry out their respective function for the elderly. Provision of geriatric and subgeriatric units in many teaching hospitals will help in teaching others how to take care of the elderly, and provision of nursing homes for a small percentage of people that might need them. Thank you for your attention.
Thank you for your great presentation and for giving us such a good flavor of the cultural differences. But I also noticed that there are many similarities, and these are the things we want to discuss now. And I would like to invite you to use the chat function. There are already many compliments in the chat function, which is really nice, but we really want to use this opportunity to discuss with you the African perspective. So I invite you again to pose questions. And I see the first questions are coming on. And the first question is from Caroline Lamas. She is from Europe, and her question is, what is the process of diagnosis in your countries? Do people come forward with a diagnosis when there is stigma attached? So this is a challenging question. Who can I give the floor? Professor Ogunniyi, can you answer the first question?
Yes, thank you very much, Caroline, for this question. The patients with dementia come to medical attention through two methods. The first one is when we conduct our research and we diagnose individuals as having cognitive problems, when we assess them for them, and then they become confirmed as having dementia. We then refer them to our colleagues in the teaching hospital to continue care. Second method is that individuals are taken to geriatric centers that are springing up. There is one in the University College Hospital Ibadan. The relations bring them because they have problems, or they go to primary health care centers where the doctors there may then detect cognitive problems, and they may then decide that they should be referred to teaching hospitals for further management. Well, the third one is they see general practitioners in town, and they then get referred. Of course, this depends on high index of suspicion, because they may present in other ways rather than coming with cognitive problem. Of course, sometimes some people go to places where people with mental health disorders are diagnosed, and then we then further process them. And those that end up with the diagnosis of dementia are then referred either to the psychogeriatric clinic or neurology clinic, and then they are seen. So those are the pathways for individuals coming to medical attention in Nigeria. Thank you, Caroline.
Thank you for your clear answer. The next question is from Dr. Ninan. Are there data on young onset dementia? Professor Ogunniyi.
Yes, thank you, Ninan. We don't have data on young onset dementia. I mean, most studies have looked at individuals who are 60, 65 and above. But we're collecting a new series, the African Dementia Consortium. We're going to look at a variety of ways in which we can access all individuals who have cognitive problems and end up with diagnosis of dementia. But currently, we don't have data on young onset dementia. But it's something that is worth noting, that we could find this in a few of our individuals that are referred to clinics. Thank you.
Thank you. And now I have a question for Professor Bahyewu. Do you think that cognitive training could be established like Qigong and yoga
Yes, I think so. It's been done in Tanzania, and I think they had a good result there. I think it's been passed also in Nigeria also, and I think but I think the Tanzania, people give. I mean, the workers in Tanzania gave it about it. It's something that is worth looking into, even though there are issues about language, about education, and also things. Because people who need going to the more educated they are, the better. And we have a lot of people who have to education. So that's what I think it's worth trying. Thank you.
Thank you. And now another question. It's a bit a critical remark. It's from Clementina Rook. Could you see they appreciate the existence of the consortium? Also, it seems to be hardly inclusive. What efforts are being made to be truly representative?
Thank you very much, Clementina. We agree with you that we have not covered every country in Africa, which will be very difficult. What Akinyemi, who's put the consortium together, what he did was to look at individuals who've published on dementia and to invite them to participate. A few individuals dropped out from some countries because they felt that their national policies will go against that. I think when the preliminary phase of the study is completed, we're going to bring in others so that to then have all representation from all parts of Africa. But at the moment, I agree with you that it's kind of selective. Some countries in West Africa and a few countries in Southern and Eastern Africa. But we'll expand on it with time once the initial phase is over. Thank you.
Well, I want to emphasize that we are very grateful for the African Consortium, and that this webinar is possible because of the efforts of the consortium. And well, it's always very difficult to be truly representative, and also to include all disciplines involved in dementia. But that's a great challenge, and you take it on board.
Yeah, thank you.
The next question is also for you, Professor Ogunniyi. How conservative do you think these prevalence figures are, owing to the fact that there is poor help seeking and due to the fact of knowledge and attribution to spiritual causes? And I want to add to this question that there are impressive difference between Africa and Europe in prevalence figures.
Yes, thank you very much. What I've done is to put together data from community-based studies. And most of these community-based studies are done by door-to-door assessment of individuals, screen and all that. So they're fairly thorough. And so I've included mainly data from studies that will be verified that they followed the door-to-door screening, and the surveillance was fairly complete. So although this may be conservative, I agree with you, but I think it's quite representative. And that's why the range I presented is so wide. I said 2.3% to about 28%. If we take away the hospital figures and we use the meta-analysis by Jagbe, we put about 5%. So it's still slightly lower than what we have in Western countries, which will be like between 8 and 11% or 5 to 8%. But it's fairly good to start with that, and then we'll work on it and see how we can improve it. And again, we'll come back to Africa Dementia Consortium. We're now going to look at a larger area of study, and we'll get more people recruited. So we'll then come up with more representative figure for Africa, avoiding all the knowledge and all the possible gaps that may affect prevalence studies. Thank you.
Thank you. The next question is from Natalie Stencil. Well, this is about, may I ask for the contact in Tanzania? for cognitive training because I'm specialist in it. So this is a very practical one, and I hope you can answer this now or later.
Well, I think I can send is it in published actually. And I think I can give you a reference later. But I think Professor Ogunniyi also probably has some information about that. Maybe you want to talk about that.
Yes.
Because he worked with Tanzania people also.
Yes, thank you very much. Stella Maripadik, who is a professor and a psychiatrist in Newcastle, is a person who is actually coordinating all these studies along with Richard Walker. And we can provide the reference and the address or the contact details if so required. And we have a few people on the ground in Tanzania at KCMC, that's Kilimanjaro Christian Medical Center, who are involved in these studies directly. So it's mainly taking place in high districts in Moshi, Tanzania, and we have all the details. It was part of the IDEA study on Africa. Thank you.
Well, when we announced the webinar, we already got information of the people who are involved in psychosocial interventions in Africa and also in using psychosocial interventions like meeting centers, which has been developed in Europe. And the suggestion was to look for a closer collaboration and to, and the use of existing interventions which can be adapted to the local situation in Africa. So that's one of the things we wanted to stimulate, that the things which are not commonly known, they are better known and can be better used. So I want to put this in for this moment. And there is another question from Georgina Charlesworth about diagnostic procedures. Which diagnostic procedures are used to make the diagnosis? A clinical interview, blood screen, cognitive or functional screening, and how often are scans available?
Okay. All right. Yes, I think that's a good question. In teaching hospitals, there are standard diagnosis procedure, ICD-10 and DSM-4 or 5 in some centers, used by clinicians, psychiatrists, and neurologists, generally. In my center, we had for a long time been using CIRAD to supplement diagnosis, in patients who have dementia. That is at the Gerardi Center in Ibadan. So we also have facilities for neuroimaging, CT scan, and MRI. All these are available. And I think what comes out of this diagnosis system haven't been part of collaborative studies for about 30 years within Indianapolis. We have learned over the years to go through the diagnosis procedure properly. And this is now being applied at the clinical level. So next thing I want to talk about this psychosocial stimulation. I think it's an important thing. We welcome it. I also say that actually we have such in our center here. The psychogeriatric center here has people who are trained to psychoeducate family members. They also have what they call I Can Dance, which is a group meetings which they have from time to time, and they learn people to socialize. But I think we accept help, and that is quite welcome. If we have the proper contact, I'm sure we'd like to collaborate and seek such help. Thank you.
Thank you. I want to use the opportunity to raise a question which is in my head. So you emphasize the cultural differences and the obligations families feel to take care of persons with dementia. How is it about the collaboration within families? Is it in Western Europe, it's often one person who takes care. How is this in Nigeria? Is this the family or one person? Or
there's a slight difference. Usually, the female members are primary caregivers. Young family members, either daughters or daughters-in-law, like I mentioned. But they live in a communal environment, so others also have input. But as I must say that there's a little problem now because of urbanization. Some people are leaving the local villages to go and seek for work in urban centers. So that is having an effect on that. The second is that, level of poverty is high. But one thing is clear, when there is disturbing BPSD, like delusions, like hallucination, which is embarrassing to family, they themselves bring sort to hospital or to a primary health center because they realize that this might be, for my colleagues in the psychiatric hospitals have special units for, for dementia and such and related disorders. So they realize that, they can get help in these centers. And we also assist them when they are registered in hospital. We follow them up occasionally by telephone as well as support for the family. We call them on phone and they can, especially during this COVID period, we are following them on phone and we discuss with them what the problems were and we ask them when to come to hospital. So it's we have a lot of collaboration with family because we know that nursing home cares are unpopular. Even if they are coming up now, some are coming up, but it's still unpopular.
thank you. And then there's a question from Ori McDermott from Nottingham. And she has a question on, do you have any thoughts on how to tackle stigma attached to dementia and mental health from an African perspective? So the special African perspective to tackle stigma.
I think the most important problem is education and access to health. People come to hospital when they have the knowledge and they have the access to health and they have the means. So poverty plays an important role in this. Dr. Wakwe, which Professor Ogunniyi referred to, wrote a paper in Eastern Nigeria at one time that people find difficulty in transporting family members to hospital. So, and I think with the development now, the idea is to upgrade the primary health centers close to the rural areas so that they can access this properly. The next is now to train people in the family health centers to recognize the signs and symptoms of dementia and either treat if they can or refer as appropriate. I agree there's a difference between the city centers and the rural areas. It's a big difference. And we are not, but my understanding that the higher the education of the family members or the caregivers, the more economically robust they are, the better they seek healthcare. And I think that's the way to go.
Thank you. And the last question is for Professor Ogunniyi from Christine Luckham. Regarding the additional risk factors specific for Africa, is there a correlation to a specific form of dementia?
Thank you very much, Christine. At the moment, because of the small sample size, it's very difficult to ascribe them to any particular form of dementia. Although we know that Alzheimer's disease appears to be the most predominant type, we still can't say that it's mainly because of Alzheimer's disease or there is any association. These are things that will be developed further with more additional data available. Thank you.
Thank you. Well, Before I end this session, I want to apologize for the problems in the switches between the presentations. But luckily the technique is working very well for the rest of the symposium, of this webinar. And I thank you very much for having taken the opportunity to pose questions and for your excellent answers. And in order to, before ending, Christian, can you post the last slides? There's also information on the next webinar. The next webinar will be at the IPA conference in Lisbon, Sunday, 2 July at 8:30 Central European Time, and it will be on the role of social connectedness in the multifactorial dementia syndrome. Does social life matter? Is the question we want to raise. Unfortunately, it's not possible to have a webinar in this way so that everyone can join without cost. It's a live webinar, which is a great occasion. And before ending, I also want to stress that you fill in the information and the evaluation form. And we always offer the opportunity to raise new topics, which we can address in the next webinar. And this is what I want to mention at this moment. And I thank you very much for joining and for actively joining the excellent presentation and the excellent questions. And I hope to see you back next time or in Lisbon. Thank you very much.
Thank you and bye-bye.
Thank you. Bye.
Bye.